Is Anastrazole better than Letrozole? Do you worry that you're on the wrong drug? Are you anxious that you only take it for 5 years instead of 10 like tamoxifen? Are you struggling to cope with the side effects? Today, I'm going to answer all these questions and more, and if you stay to the end, I'll tell you why some breast cancers develop resistance to these drugs. I'm Dr. Liz O'Riordan. I'm a breast surgeon who's had breast cancer, and I've taken both Anastrazole and Letrozole in the past, so I know what I'm talking about. And I do the research so you don't have to. Before I get into how they work and how to cope, I'm going to get straight to the point. Which is better, Anastrazole or Letrozole? There isn't actually a lot of data to directly compare the two when it comes to recurrence rates and survival. The results from the small trials that have compared them both show that there is no clear advantage for one drug versus the other at the present time. Both work equally well at reducing the risk of your breast cancer coming back. So how does your oncologist know which one to prescribe? It often comes down to the drug that your surgeon or oncologist is more familiar with, the one they've been prescribing the longest. However, there are several head-to-head trials comparing the drugs against each other, so this may change in the future. How do Anastrazole and Letrozole work? Well, they are drugs called aromatase inhibitors, and they're used to treat breast cancers that have estrogen receptors on the surface of the cells, ER-positive cancers, and 70% of breast cancers overexpress the estrogen receptor. When estrogen attaches to these receptors, it stimulates the cells to grow and to divide. Estrogen is a female sex hormone that is produced by your ovaries until you enter the menopause. Now, when you're menopausal, your ovaries stop working and you then produce estrogen in your fat and muscle. An enzyme called aromatase converts the sex hormone androgen into estrogen. And there are two types of aromatase inhibitors, steroidal and non-steroidal, which simply refer to the chemical or molecular structure of the drugs. Anastrazole and Letrozole are non-steroidal aromatase inhibitors, whereas exemestane, which I'll talk about later in another video, is steroidal. They both work by binding reversibly to the aromatase enzyme. Now, this stops that enzyme turning androgens into estrogen and drastically lowers the amount of estrogen in your bloodstream by about 85% of that of a normal menopausal woman. And that's why the menopausal side effects are more severe than for people taking tamoxifen and anyone going through the menopause naturally. Why can't premenopausal women have Anastrazole and Letrozole? The reason is this: before the menopause, your ovaries produce estrogen, like I said. If we give premenopausal women these drugs, even though they stop the aromatase enzyme from making estrogen, your ovaries are still producing large amounts of estrogen, which would stimulate any ER-positive breast cancer cells to grow. And that's why we only give them to men or women who are menopausal or premenopausal women who've had their ovaries turned off with a drug like Zoladex. So how are Anastrazole and Letrozole used to treat breast cancer? There are 7 reasons why your doctor might give you these drugs or swap you from one to another. 1. You're menopausal with an ER-positive breast cancer. If this is you and you've got a medium or a high risk of recurrence, you'll be given an aromatase inhibitor after your surgery to try and stop it coming back in the future. Now, your doctor works out your risk of recurrence using a computer program such as NHS Predict in the UK or Adjuvant Online in the US. And these algorithms, based on thousands of women from trials, compare your breast cancer with loads of women with a similar tumour to tell you what the benefits of hormonal treatment are for you. A medium or high risk generally means women with positive lymph nodes, tumours that are larger than 5 centimetres in size, or they're a grade 3. And the data from lots of trials has shown that the aromatase inhibitors lower the rate of recurrence more than tamoxifen, which is why they are the first drug of choice for women like you. If you're menopausal and have a low risk of recurrence, or there's a reason why you can't take the drugs, you might be given tamoxifen instead. And although most men are given tamoxifen, some may be given an aromatase inhibitor. The second reason is that you're premenopausal with a high risk of recurrence. If you have an ER-positive breast cancer and this is you, your oncologist may recommend switching your ovaries off with Zoladex injections to make you menopausal so they can give you an aromatase inhibitor like Letrozole or more commonly exemestane, and I'm doing a video on that shortly. The third reason is to help with the side effects. If you're struggling to cope with the side effects, and I'll talk about these in a bit, on one drug, your doctor may swap you to another. And this happened to me. When I had a local recurrence on tamoxifen, I was still premenopausal, so I was started on Zoladex and Letrozole. But I developed carpal tunnel syndrome, which is really painful wrists, especially at night, and I was switched to Anastrazole, which really helped. The fourth reason is as part of a trial before your surgery. You might be given an aromatase inhibitor for 2 weeks before your surgery as a part of a trial to see if it improves outcomes in the future. In the UK, this is the POETIC trial, which is still recruiting patients. The fifth reason is that you have the drugs instead of surgery. If you're not well enough to tolerate an operation, either by a general or a local anaesthetic, you could be given just an aromatase inhibitor. And this often happens with elderly, frail patients. And in most cases, the cancer will start to shrink over the following months and years. The sixth reason is for a local or loco-regional recurrence. If, like me, you've had a local recurrence on tamoxifen or Anastrazole, for example, your doctor might swap you to Letrozole. And number 7, the final reason is to treat ER-positive metastatic or stage 4 breast cancer. If you've developed metastatic breast cancer that's spread to your organs or your bones, for example, your doctor may give you an aromatase inhibitor as part of your hormone therapy. But this will depend on the treatments you've already had for your primary cancer and the other targeted therapies you're getting. How long do you take Anastrazole and Letrozole for? Well, it all depends on the first drug your doctor prescribed you. If you were started on tamoxifen, your doctor may switch you at the 2-year point to Anastrazole or Letrozole for another 5 years. They could also put you on an aromatase inhibitor for 2 years if you finished your 5 years of tamoxifen, and this is all based on trial data. If you started on Anastrazole or Letrozole, it all depends on your risk of recurrence for how long you take the drugs. Everyone takes them for 5 years as a standard. But if you've got a medium or a high risk of recurrence, you might be asked to take them for another 2 to 5 years. And again, it's all based on trial data and things are changing all the time. So when your doctor reviews you at 5 years after your diagnosis, they'll be able to give you an up-to-date decision about how long you should stay on the drugs for. The PREDICT algorithm now has survival data for after 5 years of treatment, and this can really help guide your oncologist when they work out how long to keep you on an aromatase inhibitor for. Why doesn't everyone get 10 years of an aromatase inhibitor? The main reason that we don't put you on Anastrazole or Letrozole for 10 years, like tamoxifen, is because of the serious risk of bone thinning and bone fractures. Without any estrogen, your bones start to weaken and thin, and this means you have a much greater chance of breaking your bones after a really simple fall. And I'll tell you how to improve your bone strength later in the video. So how do you take Anastrazole and Letrozole? Well, the dose of Anastrazole is 1 milligram and the dose of Letrozole is 2.5 milligrams, and they are small white tablets that you take at the same time every day. Some prefer to take them in the morning, others at night, depending on the side effects you have and when you get them. I took mine at night. Now, you may also be given a bone health supplement like calcium and vitamin D just to help boost your bone strength. Your GP or family doctor will be asked to arrange a DEXA scan or a bone strength scan, which looks for evidence of bone thinning and weakening called osteopenia in the early stages and osteoporosis when it gets more serious. If you do show signs of bone thinning, your doctor will talk to you about bisphosphonate treatment to strengthen your bones. More on that later. So, why do you get side effects? When your ovaries stop working, you feel the effects of a lower level of estrogen in the body. And these side effects are similar to a natural menopause. But because Anastrazole and Letrozole stop you making any estrogen, your estrogen levels are almost non-existent. And that's why you have extra side effects compared to someone taking tamoxifen. Estrogen is a natural lubricant, and without it, many women experience pain in their muscles and joints, and it can take longer to recover from an injury. And as I mentioned earlier, your bones start to weaken and thin, putting you at an increased risk of breaking your bones. And that's why weight-bearing exercise is so important to build up your muscle and your bone strength. The common side effects of the aromatase inhibitors are, and this is a long list, so bear with me, hot flushes and night sweats, sweating, leg swelling. No, I had this. I couldn't get my jeans off at the end of the day because my ankles and calves were so swollen. Other side effects include headaches, fatigue, hair thinning, mood swings, nausea, a high cholesterol, loss of libido, vaginal dryness, joint and muscle pains, osteoporosis and fractures. It doesn't make for easy reading, but a lot of women only have a few mild side effects, and just because a side effect exists, it doesn't mean that you will get it. So, how do you cope with the side effects? They can be bad, I'm not going to lie, and they can make your life miserable. But as I said, a lot of women don't struggle, and the symptoms do generally settle down after the first couple of years. And there are also lots of things you can do, including complementary therapies and more standard drugs that can help with them all. So before I tell you how to deal with the muscle aches and pains, the fatigue and the bone thinning, I'm going to ask you to forgive me. My video on the side effects of tamoxifen will tell you how to cope with all the other menopausal things. So instead of refilming it, I'm going to ask you to watch that one instead, and I'll put a link to it at the end of this video, and I hope that's okay. So, how do we prevent bone thinning and fractures? You should have your baseline DEXA scan to see whether your bones are healthy, beginning to weaken, osteopenia, or already weak, osteoporosis. And that scan should happen every couple of years as long as you're taking the drugs. To keep your bones strong and stop them from breaking, there are two things you must do. Number one, eat a diet rich in calcium and vitamin D, such as milk, cheese, yogurt and cereals, oily fish, mushrooms and eggs. And your doctor may give you a calcium and vitamin D supplement as well, such as Adcal D3. And number two, it's regular weight-bearing exercise like fast walking, jogging, running, dancing, tennis, and strength training using your body weight with squats, resistance bands, or heavier weights in a gym. If your DEXA scan shows that you do have thin bones, you may need to take another drug to increase your bone density, and that's a drug called a bisphosphonate. It either comes as a tablet that you take every day or as an infusion into your veins every 3 to 6 months. And I'll put a link for some more info on that in the description below. So how do you cope with bone, joint and muscle pain? I get asked this a lot and it's really hard to deal with. Life's not fair at times, you've been through enough. So here are my top 5 tips to cope with bone, joint and muscle pain. Number 1, eat a healthy diet that includes enough calcium and vitamin D to keep your bones as strong as they can be. And number 2, guess what? It's exercise regularly. Both aerobic and resistance-based exercise every week. It keeps your bones strong and it helps your joints stay flexible. And research has found that regular exercise does ease the joint pain caused by aromatase inhibitors. If you just sit at home and don't move, everything gets really stiff and your muscles get sore. So although you don't want to do it, moving regularly will help. Number 3 is to try using hot or cold packs or a combination of the two if you've got a particularly sore area. Heat is really good for muscle spasms and cold reduces inflammation. Number 4 is to try simple painkillers such as paracetamol and ibuprofen if you can take it. And some complementary therapies have also been shown to help, such as acupuncture and massage. And number 5, and again I know it's hard to do, is to try to maintain a healthy weight to ease the stress and strain on your joints. One of the biggest things women struggle with is how to cope with the fatigue, that bone-shaking tiredness that comes with cancer treatment. And here are my top 5 tips. And you'll start to recognise 2 of them, I'm afraid. Number 1 is eat a healthy diet with lots of fresh fruits, vegetables and lean protein. And the second one, actually the one that works the best, is to exercise regularly. It helps improve your stamina, and studies have proven that it has the biggest impact on fatigue, even though it's the last thing you want to do. And trust me, I've been there. It really does work. Try telling yourself you're going to go out and walk for 5 minutes, and if you can't do it anymore, you'll turn around and come home. Most of the time, I'll carry on for longer, and it does help with the menopause symptoms as well. The third is to try having a quick nap for no more than 30 minutes so you don't fall into a deep sleep. If you're finding you need a nap every day, then try and take it at the same time, but don't do it after 2 o'clock. Number 4 is to try and stick to a strict sleep routine if you can. Go to bed at the same time and get up at the same time each morning, and try not to hit the snooze button, although I still do it, so I don't practice what I preach. Number 5, if you know you've got a hard day coming up, plan an easier day afterwards if you can, to let your body and your mind recover. It's really important to pace yourself. You've got to be kind and accept that you might not be the powerhouse you were before treatment started. But what if you're still struggling? There are things you can do, and the first is ask your doctor if you can switch to a different aromatase inhibitor or tamoxifen to see if that helps with the side effects. The second is to ask your doctor about a small treatment break for a couple of weeks or months. And finally, you could ask your doctor to see what the actual benefit from letrozole and anastrozole is using the predict tool. If that benefit is only small and you've got a small, low-grade, node-negative tumour, you might decide that you've had enough and stop taking it altogether, hoping that your breast cancer won't come back in the future. And if you do stop taking letrozole, make sure you do the 3 things that reduce the risk of it happening: regular exercise, cut down on alcohol, and maintain a healthy weight for your height. Before I get to the bonus section, if you found this video helpful, make sure you subscribe so you don't miss next week's one. Now, why might your breast cancer come back after taking anastrozole and letrozole? Aren't they meant to work? So although surgery removes the breast cancer, there is still a chance that some breast cancer cells that are microscopic, too small for the human eye to see, have left the breast and started to move around the body. Now they can stay dormant, which means they're asleep and not actively growing, like a hedgehog that's hibernating, for tens of years. Most of them will stay dormant or die, but some do wake up, find a friend, and start to grow. And these cancers can continue to mutate and change and can develop resistance to previous treatments. Now, studies in animal models have shown that this can happen in several ways. One is that the cancer becomes hypersensitive to the very low levels of estrogen you have, which is what happens when you take anastrozole and letrozole. So suddenly, that tiny amount of estrogen that you have left in your bloodstream now has a massive impact on the remaining cancer cells, stimulating them to grow. Another way is that the cancer cells themselves increase the production of growth factors that make them grow faster, a bit like producing their own stimulants, so they don't need estrogen anymore to carry on dividing. If you do get a recurrence when you're taking anastrozole or letrozole, your doctor will swap you to a different form of hormonal therapy that your cancer cells have not yet been exposed to, which will hopefully slow down or stop the cancer growing for several months or years. I'm Dr. Liz O'Riordan, and thanks for watching my channel, and if you've still got a question, let me know in the comments.